opioid prescription changes with the addition of chiropractic services. Once again, we have a study demonstrating a benefit for chiropractic care at decreasing the utilization of opioids for pain. What is unique, though, is that this study demonstrates changes in patient management after chiropractic services are integrated into a primary care clinic who had already changed their prescription protocol in an effort to decrease utilization of opioids. To date, there is a relatively large body of evidence across different patient populations that provide at least emerging evidence that regardless of patient population, the use of opioids, even when prescribed, and the costs of care go down when comparing patients treated for spinal pain by chiropractors versus those managed with medical care, in particular during the initial acute phase. Let's look at a recent systematic review and meta-analysis I reviewed last year as a summary of that data first before reviewing the most recent study. The study was published in Pain Medicine, Association between Chiropractic Use and Opioid Receipt Among Patients with Spinal Pain, a systematic review and meta-analysis. Notice a few things. The question isn't whether chiropractic care is the cause of a decrease in opioid use, or whether chiropractic care is better than care using opioids, or whether chiropractic care costs less or is better when incorporated into a multidisciplinary setting. The question posited is there an association between chiropractic care and opioid use? A very specific question in some ways, but broad in others, in that only an association is required for included studies. So a lesson in the interpretation of studies is that most look for associations, not cause and effect. In this case, whether chiropractic care is associated with a decrease in opioid use. That means as one variable changes, such as chiropractic care, does the other variable, opioid use, change, and to what degree and how consistently? So statistically, the proportion of patients receiving opioids was calculated for each individual study for the group receiving chiropractic care and compared with the group that was not receiving chiropractic care. Although this may seem like semantics, it's not, because if chiropractic care is associated with decreased use, there may be many causes, including patients' behaviors, doctors' behaviors, types of techniques or management approaches, etc. In other words, all patients did not receive the same chiropractic care. So the purpose is not to discover what the underlying cause or causes are for the decreases, just the association. And note for this review, studies that evaluated chiropractic care as part of a combined multidisciplinary approach were actually excluded unless the chiropractic care portion was assessed separately, so that the study we'll soon review would not have been included in this review, given its specific context of interdisciplinary care. So first of all, what is a systematic review? Researchers find all related high-quality studies for the topic and outcome chosen, in this case, chiropractic care associated with opioid use for patients with spinal pain. If the patient's outcomes and statistics are similar in the studies found, they can be combined in essence into one larger total cohort of participants, turning it into a more powerful statistical estimate of effect, basically a mega study made up of all the other studies. We must always remember that not all studies have similar results. Some may show no effect compared to another treatment or measure, while others may demonstrate a different, even opposite effect, even though addressing the same topic. What happens when they're combined gives the larger picture in a meta-analysis, and if statistically similar, a graphical representation called a forest plot, seeing the forest of studies instead of the individual tree of a single study. So the forest plot for this meta-analysis is a skeletal depiction. For more detail, please access the article itself. All 6 studies' statistics, odds ratios, and confidence intervals fall well below the center line, indicating a consistent effect of reducing opioid use, and the confidence interval lines not shown here are quite small, meaning the studies on average were quite large, demonstrating a very predictable effect. The summary diamond is then below 0.5, representing more than a 50% reduction. In fact, this reduction, on average, was 64%. So specifically, in total, there were 6 studies in this systematic review that met the criteria and were included in a meta-analysis with the corresponding forest plot. Now, looking at chiropractic care among patients with spinal pain in these studies, sadly, it varied between only 11.3 to 51.3%. In other words, patients saw other practitioners more often. The percentage of patients receiving an opioid prescription was lower for chiropractic users. The range was between 12.3 to 57.6% than non-users, where the range was 31.2% to 65.9%. Now to our current study. What was the purpose of this study, and what was unique? It was to describe changes in opioid therapy use after a family medicine practice included on-site chiropractic services. There were different phases studied based on before and after the introduction of chiropractic care in a family medicine practice from April 2015 to September 2018. Phase 1 was before chiropractic integration and before changes in prescribing practices in the medical practice. Phase 1 was before chiropractic integration and before the changes in prescribing practices. The second phase was after the change in prescription practices from June 2016 to March 2017, Phase 3 after the introduction of chiropractic services, and finally Phase 4 where there was an increased acceptance and utilization of chiropractic services tagged established chiropractic services from August 2017 to September 2018. The study dates included 24 months before and 18 months after the inclusion of chiropractic services in this practice. Integration of chiropractic services took time culturally and procedurally over about 4 months. What resulted was an efficient flow of routine office care to include patient referrals from a medical visit to a chiropractic visit at the same appointment time. The development of self-evident criteria for referring patients for chiropractic care, and the opportunity and ability for medical providers to educate their patients about the benefits and risks of chiropractic care. So what was self-evident referral? Criteria were any and all new onset of musculoskeletal pain of the spine, extremities, chronic musculoskeletal pain of the spine, extremities, and headache, either on or not on prescribed medications. So the patients reporting musculoskeletal pain or headaches of acute or chronic nature during their primary care visit were asked if they would like to be evaluated by the on-site chiropractor. Part of what was compared was based on drug classifications by the FDA for controlled substances. This drug classification schedule organizes drugs into groups based on risk of abuse or harm. Schedule 1 drugs are those drugs with high risk and no counterbalancing benefit, and they're banned from medical practice. They include the hallucinogenics, such as LSD, marijuana, peyote, ecstasy. Schedule 2 drugs are designated to have high potential for abuse, which may lead to severe psychological or physical dependence. This is the main category for opioids, including drugs such as Dilaudid, Demerol, OxyContin, Percocet, morphine, opium, and codeine. Next is Schedule 3, designated as having a potential for abuse less than substances in Schedules 1 or 2, but abuse may lead to moderate or low physical dependence or high psychological dependence. These are the pain meds, which include mainly combined opioids. They are combined with either aspirin or acetaminophen, such as acetaminophen and hydrocodone, which is Vicodin, and products containing no more than 90 milligrams of codeine, such as Tylenol with codeine. Now to Schedule 4 controlled substances. They have a low potential for abuse relative to Schedule 3, and these are primarily the benzodiazepines, or BZDs. These include Xanax, Valium, and Ativan, among others, but also this category contains the opioids Darvan and Darvocet. So how are the opioid rates measured? Opioid calculations included a breakdown of the average monthly rate of opioid prescriptions by controlled substances, Schedule 2, Schedule 3, and Schedule 4, and the morphine milligram equivalent, or MME, per opioid prescription. The MME included dose, number of pills, and number of refills. Opioid dosages at or above 50 MME per day increased the risk of substance abuse and overdose deaths. There was a significant decrease of 22% in the average monthly rate of opioid prescriptions after the inclusion of chiropractic services. The likelihood of writing an opioid prescription after the inclusion of chiropractic services decreased by 5%. Adjusted for seasonal variations and changes in opioid medication practices, the likelihood decreased by 6 and 7%, respectively. There were also significant differences in the average monthly rate of opioid prescriptions among the 4 practice phases. Changes in practice phases accounted for about 63% of variance in the average monthly rate. Although there was a significant linear decrease in the number of monthly opioid prescriptions across all 4 phases, a significant decrease from baseline was only detected after chiropractic services were established. The likelihood of writing an opioid prescription after chiropractic services established decreased by 8% from baseline. And the likelihood of writing a Schedule II opioid prescription decreased by 27% after the inclusion of chiropractic services. The relationship between controlled substance schedules and the 4 practice phases show changes in opioid medication practices to include prescribing a Schedule III or IV opioid rather than a Schedule II opioid. And this relationship between schedule and practice phase described about 70% of the variance in prescribing rates. And it's important to note what they did not study. They studied associations to changes in opioid prescription with and without chiropractic services, but the observed statistical findings cannot be used to infer a causal relationship. So which of the 2 approaches worked? Changes in prescription practices prior to chiropractic or chiropractic? Well, both did. The association of daily doses of opioids with changes in opioid medication practices and inclusion of chiropractic services accounted for decreases in the likelihood of opioid therapy use by 30% for the changes prior to chiropractic and 45% after. Even with all of the existing evidence, we're still missing some pieces of the puzzle. There is evidence of decreased cost of care, decreased utilization in areas with more chiropractors, and a decreased likelihood of filling a prescription if a patient sees a chiropractor. But what we still don't know is if these decreases in opioid use are because chiropractic care is more effective or because patients self-select chiropractic care, which then leads to a more likely result of decreased use. Certainly, future studies will need to address this important clinical question, but in either case, policymakers, insurance carriers, and patients should be made aware of the potential ability for decreased opioid use and cost with chiropractic care.